Hello everyone. Here we are going to cover a topic that is neonatal jaundice, also known as congenital hyperbilirubinemia. So in your university exam, you usually get a short note or very short note on one of the important 5 causes of neonatal jaundice. So we will be discussing 5 important causes of neonatal jaundice here. That is Gilbert syndrome, Crigler-Najjar syndrome type 1, Crigler-Najjar syndrome type 2, Dubin-Johnson and Rotor. So in your university exam, you get a short note on any one of them. 5 of them, but rarely you can get a long question. If you're getting a long question, you have to write down all 5. So let's start it. Here you can see neonatal jaundice, also known as congenital hyperbilirubinemia. So let's start it. So first of all, I will let you know the definition of neonatal jaundice. What do you mean by neonatal jaundice? Then we will see its classification. Among the classification, there are many causes, but 5 are ultra important. Then we will see the details of the 5. Which 5? Can we see the 5? The first one is the Gilbert syndrome. The second is Crigler-Najjar syndrome type 1. Then Crigler-Najjar syndrome type 2. Crigler-Najjar syndrome is of 2 types. Type 1, type 2, we will see both. Then Dubin-Johnson syndrome and Rotar syndrome. We will see these under a fixed set of heading, that is their inheritance, because they all are congenital. Their inheritance, hyperbilirubinemia type, is it conjugate hyperbilirubinemia or unconjugated hyperbilirubinemia? We will see that. Then what is the most important defect? The most important thing is the defect. Then clinical course, effect of phenobarbital, hepatic morphology and prognosis. So we will make a comparative table between all 5. I will show you the table. But before understanding all this, let's revise the bilirubin metabolism. How does the bilirubin get synthesized and it is metabolized in human body? We will see entirely everything about the bilirubin. So you can see this is a human blood vessel. Let me tell you how does bilirubin get synthesized. You can see this is a human blood vessel. In the human blood vessel, we have RBCs. Inside the RBCs, there is hemoglobin. When after 120 days, the RBCs are destroyed. We know the lifespan of RBC is 120 days. So after 120 days, the RBCs are destroyed inside the phagocytes. So hemoglobin comes out. From the hemoglobin, heme come out. This heme get converted into biliverdin and biliverdin convert into bilirubin. So basically, the bilirubin is synthesized in the lumen of the blood vessel. In the lumen of the blood vessel, this bilirubin is synthesized from the heme of the hemoglobin. So this bilirubin is coming from heme of hemoglobin, that is bilirubin. Now this bilirubin is unconjugated bilirubin. This bilirubin is unconjugated bilirubin. It will bind with albumin in the blood and transport it from here and there. So it is binding with albumin, but still I will call it unconjugated only. It is binding with albumin. When it is binding with albumin, now it will go to the liver. Can you see a liver? Now have a look on the liver. Now we will start the hepatic phase. This was the synthesis. We have seen how the synthesis takes place in the blood. Now it will go in the liver. Liver is hepatic phase. In the liver, 3 things will taken. First, there will be uptake. After that, it's conjugation. First uptake, then conjugation, then secretion. So uptake, conjugation and secretion, 3 things will take place inside the liver. So you can see the bilirubin which is present in the lumen of the blood and it is combined with the albumin. So bilirubin will come inside the hepatocyte of the liver. I want you to appreciate this is the hepatocyte of the liver. This cell is the hepatocyte of the liver. So here 2 transporters are there. One transporter is for uptake of bilirubin from the blood and second transporter is secretion of the bilirubin into the bile. So 2 transporters are there on the hepatocyte of the liver. You can see this is liver. Inside the liver, we are having hepatocyte. So on the hepatocyte, appreciate the 2 transporters. This transporter is known as ligandin Y. Ligandin Y. Ligandin Y does the uptake of the bilirubin which is combined with the albumin. Free bilirubin cannot come inside. So the bilirubin which is combined with the albumin is coming inside. You all can appreciate. I'm erasing it so that you can appreciate it. So you can see this is the bilirubin present in the blood and it is combined with the albumin. So only bilirubin is coming inside using ligandin 5. This is known as uptake. So uptake took place. After that, in the cytoplasm, in the endoplasmic reticulum of the hepatocyte, inside that there is an enzyme. The name of the enzyme is UGT. That is UDP glucuronosyl transferase. The full form of UGT is UDP glucuronosyl transferase. This is the enzyme which does the conjugation of bilirubin. So basically, unconjugated bilirubin get converted into conjugated bilirubin inside the endoplasmic reticulum of the hepatocyte. So have a look on the liver. Inside the liver, have a look on the hepatocyte. Inside the hepatocyte, in the endoplasmic reticulum, conjugation take place. So first uptake take place. You can see uptake take place. In the uptake, the bilirubin is moving from the blood into the liver inside the hepatocyte of the liver. After uptake, conjugation take place. So you can see unconjugated bilirubin converted to conjugated bilirubin. Now we want to secrete the conjugated bilirubin into the GIT, into the intestine. So here another transporter is required.